You're good.
Good morning, everyone. Welcome to Grand Rounds, August the 17th. 4 days to the eclipse. Everybody's got their glasses, hopefully. So today's speaker is Dr. Jason Faulhaber from the Department of Infectious Diseases. He is the Associate Program Director for the Fellowship Training Program. Dr. Faulhaber comes from New Jersey. He trained at Robert Woods Johnson Medical School and went all the way over to New York for his residency and fellowship at St. Vincent's Medical Center and New York University. He's worked for many years prior to coming to Carilion in 2012. He has written numerous chapters in the infectious diseases books on acquired immunodeficiency and immune system. Yeah. That's about my extent of immune knowledge. And comes to us today to educate us all about current topics in the HIV world. Thank you.
Thank you. Good morning, everyone. I see everyone has avoided the spittle zone here, just in case. Nothing to worry about. I'll be quite dry. I have no disclosures, not because I didn't want to. I apparently missed the boat when I did that. So we're going to look at clinical situations where you're going to use pre- and post-exposure prophylaxis. I'm going to go through some of the current guidelines looking at the treatment. Oh, okay. And we're going to discuss some of the long-term as well as some short-term risks and effects of antiretroviral use. So we'll start with the pre-test. I know it's early in the morning. This is the last thing you want, but I'm not going to score you, so it's only one question. So in which of the following situations is the use of post-exposure prophylaxis for the prevention of HIV infection appropriate? So you have a 26-year-old pediatrics intern who sustains a needle stick during placement of a central line and a 17-year-old patient who is perinatally infected with HIV. You have a 16-year-old homeless adolescent male who exchanges sex for money in order to live. Or you have a newborn infant whose mother never received prenatal care and has a positive rapid HIV test. Or you could probably just take a stab and go for D, all of the above, because if it's there, clearly it must be the right answer.
Oh, yeah.
So we're going to start with just some basic epidemiology. We know that there's at least 1 million people living with HIV in the U.S., where 1 in 7 are unaware of their status. We have about 40,000 newly infected individuals in the U.S. on an annual basis, and this has been pretty steady, slightly declining over the past 3 to 5 years. And the most recent one of data collection from 2009 showed that 61.3% transmissions are diagnosed but not in medical care, and we'll see something a little bit more recent from our own VDH. And 30% of HIV infected are undiagnosed, and less than 10% are retained in medical care regardless of whether they've received antiretroviral therapy or what their viral load is. And that's going to set up our situation for pre-exposure prophylaxis. In Virginia, we are ranked number 13 for annual new HIV diagnoses, and overall it's the 20th in the highest rate. Over the past 10 years, we've had about 1,000 new cases, again, roughly about the same every year. And the highest rates of new infections are basically between 15 and 34 years of age, with 25 to 34 leading or just beating out the 15 to 24. And males who are 25 to 34 are more than 6 times as likely to be diagnosed with HIV than females of that same age. So when we talk about prevention and use of antiretroviral therapy, these are the 4 main ways that we can do it. Treatment as prevention, or TAP or TAS, prevention of mother-to-child transmission, post-exposure prophylaxis, and pre-exposure prophylaxis. I'm going to kind of go backwards. I'm going to start with pre-exposure. This would be before you would have the exposure. So this is using some antiretrovirals in those who are uninfected in order to try to prevent HIV infection. So your ultimate goal is to reduce the rate, thereby increasing or resulting in morbidity, mortality, and cost being less. And this requires a lot more than just prescribing. It's not just here, take the script and go. You have to do a lot of education, provide a lot of support, and, of course, regular monitoring. The characteristics, namely, you want a drug to be safe, obviously. That it has to penetrate those tissues that are at highest risk for acquisition. It needs to protect against HIV in those tissues. and it needs to have long-lasting activity with easy, convenient dosing. There are going to be other things. Obviously, you want to minimize the amount of drug-drug interactions if there are, and of course, you want it to be affordable and easy to use, which is maybe a problem in some areas. So the WHO, if you notice on their recommendations, that it should be offered to any individual who is at substantial risk. And that is going to be basically with an incidence of more than 3 per 100 person years. And you want it to be cost effective where the incidence is also greater than that. So it's in the same area. Note that there's no age limitation for this. The CDC, on the other hand, is very wordy, as usual. But they're saying that in cases of serodiscordance, where one partner is infected and the other partner is uninfected, would be one that you want to use. Any man who has sex with men and who has sex without a condom, basically in the past 6 months, a history of sexually transmitted infection, or at least known to have more than one partner, would be a suitable individual. And anyone heterosexual man or woman who is known to be at risk and is not in a mutually monogamous relationship. And then anyone within the past 6 months who has injected illicit drugs or shared paraphernalia. The USPHS says that it is an option for those who are sexually active adults, and their definition of adult is at least 18 years of age. And really anyone who is at substantial risk, including serodiscordant couples. And the reason for this is because the data for adolescents has been rather sparse. Also note that they haven't really updated since 2014. So when you look in general for your risks, it's going to be based on what the prevalence of the virus is in that community, the partner's risk factors, whether or not they are incarcerated, other substances, alcohol and illicit drug use, sexual work, having recent sexually transmitted infections. Some of them certainly increase the risk of transmission for HIV, notably the ulcerative diseases, but also syphilis. And sporadic condom use will do it. So when we talk about adolescents, since we're in the peds, we know that it is a worldwide issue that we have to deal with. It is the second leading cause of deaths worldwide in adolescents. And about 2 million adolescents are currently living with HIV in the world. In 2013, it was approximated that every 2 minutes, someone aged 15 to 19 was infected. Every 2 minutes. And projected by 2050 that there will be approximately 1 billion Africans under the age of 18 who are infected with HIV, if we continue at the rate that we're at. And we know that for adolescents, there is certainly an increased risk because of, well, they're going through lots of transitions, biological as well as psychological. Part of that is establishing their identity. There are occasionally age and power imbalances, as we know, and certainly there's an inequality with gender. So these individuals are much more likely to be at risk. So I'm going to talk about 2 specific adolescent trials. First one is 110, and this enrolled 200 U.S. adolescents aged 18 to 22. And as a demographic, 55% of them were Black, 17% were Hispanic. They had self-reported high-risk behaviors within the previous 6 months. And PrEP was given, and they were followed up at weeks 4, 8, 12, 24, 36, and 48. So you note early together, closer, a little bit further apart, a little bit further apart. In general, it was well tolerated. There were 4 seroconversions by the 4th year, for 48 weeks, 1 year. And they were all in individuals who had undetectable drug levels. And those who engaged in condomless sex had higher drug levels overall. So those who knew that they were putting themselves at risk were certainly the ones who were most likely to be well prepared and taking the PrEP, as we know. But as you got further out, what we found is that adherence decreased as well as the visits decreased. The other one, AT13, enrolled fewer, 78 men who have sex with men between the ages of 15 to 17 from multiple U.S. sites. Again, safety very well tolerated. There were 3 conversions within 48 weeks. If you compare the numbers from before, this is actually a higher rate infection. And of those 3 that did seroconvert, none of them had protective levels of the drug, including one who had no detectable levels the entire time. Again, common that less adherence would occur with increased intervals, which is different from the adult population that we see. And the most common reasons that were provided was that because they were away from home, they were too busy to take the medicine, they forgot simply, and it's just a change in their normal routine. There have also, within this study, there were comments from the subjects, and some of the comments included that, well, I didn't want anyone to know that I was taking medicine, or if they saw that I was taking a pill, they might think that I am HIV infected. And so there's a lot of fear and stigma associated with this. More specifically, looking at the young Black men who have sex with men, the CDC estimates that 1 in 2 Black men who have sex with men will be diagnosed with HIV at some point in their lifetime. And the young are much more overburdened, with a projected of 40% will acquire HIV by the age of 30. So we know that they generally have less access to preventative health information, including visits for healthcare providers. Disclosure is a huge issue, disclosing of their status, of sex, and of who they have sex with and what they do. And there is variability amongst the providers who actually provide the medication as well as care. It's something known as the purview paradox. So those providers who are willing to provide PrEP are usually those who are in infectious diseases or have more experience, who don't see HIV negative people as often. Whereas those primary care providers who have basically are at the front line, many are not comfortable with providing this. And that goes across the board, not just for adolescents, but also for adults. And they usually rely on what they think is their perceived risk, which, as we know, is not correlative to what their actual risk is. Oftentimes, they're perceiving their risk to be much less than what it really is. And one of the studies found that 8% of 15 to 24-year-olds were on PrEP, despite 2/3 of them reporting condomless anal sex. So of the 2/3 that do put themselves at risk, only 8% were actually taking it. So we need a lot of support for the adolescents. So providing a friendly setting and staffing, supporting them with their decision-making, assisting with actually adhering and obtaining drug, and getting to them to keep their appointments. So given the way that this is all heading, PrEP is really a valuable option for adolescents, but we have to improve their access as well as their adherence. And in some locations, we know that consent can be problematic. That actually does include Virginia. So how do you do it? So you assess what their general risk is, and then you evaluate their general eligibility. So you need to always make sure that they don't have HIV to start with, and you have to make sure their kidney function is good and that they are protected against as much as they can be. I'm going to provide lots of education. It's only one part of everything that's going on, and also reiterate, not just iterate, reiterate over and over again, that PrEP does not protect against other sexually transmitted infections. And one of the big criticisms for PrEP has been the fact of disinhibition and increased risk behavior. So since I'm taking something, I can engage in more risk behavior, so I would have more or the potential for more sexually transmitted infections. And in general, it is roughly the same, or in one study, one of the AT110, it actually decreased over time, the incidence of sexually transmitted infections. So there is currently only one medicine that is FDA approved for it, which is the combination pill, emtricitabine with tenofovir disoproxil fumarate, or TDF. There is a newer version of this pill, which is a different form of the tenofovir, which is less toxic long-term, but that does not have the FDA approval for PrEP at this time. So within the adolescent population, I would monitor them at least monthly for the first 3 months. Then, depending on that, you might be able to swing it out longer to 2, maybe even 3 months, but you're going to be doing their testing based on what their risks are. So as long as you've established a good relationship with the adolescent and they're being forthright with all of their sexual activity and their potential risks, you may say, well, if you've only had one possible risk in the last month, then maybe we don't necessarily have to test everything at this time. But if you're telling me you had 7 in the last week, then maybe we want to do it a little bit more frequently. Because of the fact that the TDF can affect the kidney, you're going to need to monitor your kidney function at least every 3 months and up to 6 months after that, and continued testing for sexually transmitted infections based on the risk behaviors, as I said. Now, this is not something that you necessarily are going to keep them on for life. It's also going to depend, and this works for the adult population as well, depends on whether or not they need to continue. And if you're looking at when they're putting themselves at risk, if they are now in an exclusive monogamous relationship, which they are 100% certain of, which, being cynical as I am, no one is 100% sure unless they're literally tied to you 24/7, but that there may not necessarily need to continue the PrEP. And this is coming from CDC and the USPHS, which is just a guidance for PrEP use. And again, this is looking at, all of this is looking at adults. They have the caveat that for adolescents or for minors, it needs to be individually case-based and based on the preference of the provider. And it's mainly because it doesn't have the indications yet, because there haven't been as many studies, just those 2 major ones. So that's from PrEP. Moving on, so you have the prevention of mother-to-child transmission. You know, this is where we've had a huge breakthrough. Without any intervention, it could be up to 42%, and with intervention, it is down to less than 1% transmission to infants. And within Virginia, within the past year in 2016, there were only 4 cases of children that were infected, not necessarily babies, but children infected in less than 10 years of age. And within our close vicinity in Southwest Virginia, we've had 0 babies that were born infected. So antepartum for the mothers, you want to start antiretroviral therapy as soon as possible, ideally in order to obtain a viral load that's undetectable by the time of delivery. Intrapartum, if the viral load is detectable and greater than 1,000, you're going to go for a C-section, and you're going to provide intravenous zidovudine, or AZT, as you may know it. Postpartum, you're going to continue the mother on antiretroviral therapy because at this point, recommendation is for everyone to be on antiretroviral therapy. And you're going to provide post-exposure prophylaxis for the infant, which we will get to, and you're going to talk about contraception. So at this point, all infants who are potentially exposed to HIV should receive post-exposure prophylaxis postpartum. And it should be initiated as soon as possible, ideally within 6 to 12 hours. You can use a 4-week regimen if the mother is undetectable and you have no issues or concerns with adherence. If, however, there is concern or you have a positive viral load prior to, you're going to extend it out to 6 weeks. And that will also consider either a single drug, zidovudine, or the combination, especially if the mother didn't receive any antiretroviral therapy before or intrapartum, if they only used intrapartum or they were not fully suppressed. And if you have a mother of unknown status, you would only provide the PEP if the expedited testing was positive. You know, that expedited testing is a little bit different than the regular testing that we do. So the main drug that we use here is zidovudine, or AZT. And you can see the regimen here. You don't have to have this memorized. You can always just look it up. We have it on our Carilion guidelines online. And you're going to go through at least 4 weeks, like I said, but up to 6 weeks. The use of nevirapine would be for any infant who is at higher risk, and I'll explain which ones are higher risk. And there is a push elsewhere, and they're looking into this, and we'll see in the next year or 2, for the possibility of having a 3-drug regimen for post-exposure prophylaxis for the infants, and we're going to talk about that too. You're going to get your general baseline labs, you're going to do follow-up, and the virologic testing is going to occur somewhere in the first month of life, then after the first month, up to 2 months, and then the last one ideally between 4 and 6 months. And any infant that is born to someone who is known to be HIV infected should begin pneumocystis prophylaxis at the completion, so not during, but at the completion of your post-exposure prophylaxis, unless you know that HIV has been completely excluded, which, as you know, is a little bit difficult, as we're going to see, to do that since you're going to go 4 to 6 weeks, and that puts you in here. So under 18 months of age, the two tests that can be used are the RNA and the DNA PCR. The DNA PCR was the original test that was used, and it is favored by many just because it is not affected by antiretroviral therapy, whereas RNA is certainly easier to get done and it's faster, and in many of the studies, it is just as effective at detecting. And we said what the testing was, and you definitively are uninfected if you have at least 2 negative virologic tests that at least are occurring after the 1-month period and 1 after the 4-month period. They have to be 2 negative tests. And as you know, we're using RNA or PCR, not the antibody test, since the antibody test in this period is going to likely pick up the maternal antibodies. And so it would be falsely positive. If there is a behavioral exposure, so just throwing this in here from a testing perspective, you're going to use this antigen antibody, or what's known as the 4th generation test, which is a combo test that can detect HIV as early as potentially 10 days after infection. And that's a combination looking at the antigen and the antibody. You can also use the PCR, and in this case we use RNA instead of the DNA. And you're also going to look for sexually transmitted infections. So going back to the infants, you've got low versus high risk. The low risk are going to be those where the mother is on antiretroviral therapy and has a fully suppressed viral load. Up here, so you're going to do the testing, the NAT, which is the nucleic acid testing. This is the RNA or DNA PCR. You're going to do it somewhere between 2 weeks and 4 weeks, then between 4 weeks and 8 weeks, and then between 4 and 6 months. Or the higher risk is basically all the others. So a mother who has unsuppressed, not fully suppressed, detectable viral load, if there is a potential for acute HIV infection during pregnancy, or mothers who have never had prenatal care or weren't on antiretrovirals prior, then you're going to likely do additional testing during that time. And we're going to talk about how this becomes important. For treatment, we know that without it, more than 50% of infants will die by the age of 2. And it is at this time recommended for all children who are infected. There's a difference between urgency of the treatment versus just wanting to treat. And there is more urgency if you have infection diagnosed in infants or children less than 1 year, if they have an opportunistic infection or they have a low CD4 count. And that CD4 count is going to be based on age. That it's going to change. And you can use an absolute or you can use the percentage. And the regimens that we use are going to also be dependent on age versus weight. Nearly all of the antiretrovirals that are available for adults, nearly all of them are available for children, but it depends, again, on age or weight. So some of them are restricted. And I've included all the antiretrovirals at the end to go through them. Mainly because you need to know what the 3-letter abbreviations that I use. It takes too long to write everything. So as you can see, it's broken down by age and what the regimen is. And as you see in all of these, again, it's a 3-drug regimen that you're going to use for treatment. And there's going to be this backbone that includes 2 nucleosides, the NRTIs. And those NRTIs, by preference, are going to be based on age again. Of course, no, it doesn't conveniently go with all the others. So either zidovudine with emtricitabine or with lamivudine, and then moving on, you can actually start to add abacavir after 3 months of age. If they're greater than 12 years of age, you can use TAF instead of TDF. As you see here, we've got nevirapine, lopinavir being a protease inhibitor, raltegravir. This is new that is able to go down to 2 years, and studies are now looking at raltegravir to go all the way down to perinatal after 37 weeks of age and greater than 2 kilos, but that it doesn't have approval just yet. And the other is that dolutegravir was recently approved for use all the way down to 6 years of age. dolutegravir is one of our most potent integrase inhibitors that we have. So this is very exciting from the treatment world. There's something we call the HIV care continuum, which is part of the National HIV/AIDS strategy. And it's based on different stages. So you're looking at individuals who are aware of their diagnosis, those who then become linked to HIV care within 3 months, ideally within 30 days, those who are retained in care, and those who are fully suppressed. So you see that for adults, 87%, which corresponds to about 1 in 7 to 1 in 8 that don't know, a good majority of them are linked to care. Only about half are retained in care, and retained in care is ideal two medical visits within 1 year, at least 3 months apart. And then virally suppressed of those who are retained in care is about 2/3, 3/4. I can do math, I swear. It's just it's early. So. Comparatively, looking at adolescents, only about half of adolescents who are infected know of their diagnosis. Big problem. And 80% of those are linked to care. Only, again, about half of them are retained in care. And even less, 60% are virally suppressed. And we know that this is the time frame that has, or is the one that is increasing incidence of infections and new infections. And most of that is going to be driven by the fact of those who don't know their diagnosis. So we know that early suppression has the potential to actually impair the development of HIV-specific antibodies. Why does that become important? Because there is the potential that you can now test seronegative for antibodies if you were to start very early. And by very early, we mean less than 2 months of age. But despite that, we know that the viral reservoir is set up quite early. And we know that if you were to stop antiretroviral therapy, then there is likely to have a rebound effect of new virus production due to these reservoirs that are difficult to eradicate. And that can happen as early as 2 weeks after and can rebound all the way up to 100,000 or higher for viral load. And we know that the concentration of antibodies that you have present is directly correlated with the size of your reservoir. So the greater the production of antibodies that you have, the larger your reservoir is. So therefore, the need to continue and stay on therapy. This leads to what we call the functional cure, and this is where the hot topic, because it's probably what you have heard of, something called the Mississippi baby. Just nod, somebody. Okay, great, you've heard it. So this was an infant who was started on antiretroviral therapy within 30 hours of life and had a detectable viral load very early on at 30 hours. And that viral load was about 20,000. And with therapy, was undetectable for 27 months after the 18 month. And then after 27 months, finally rebounded, and rebounded roughly to the level that the infant had at birth. So kind of like that set point reservoir. So it was very exciting between this 18 month and the 45 month, but there was a rebound. So what we thought could have been a potential cure ended up not necessarily being the case. The other one is in France from a trial called the Visconti. I guess in French, Visconti. But. And we're looking at HIV was undetectable at day 3 of life. This is one specific subject. At 3 months of age, the viral load was detectable at over 200,000. And so antiretroviral therapy was started up until she was 6 years of age. After that, she basically has been undetectable for 12 additional years. Kind of unique. So this is what's helping us push to the earlier you start therapy, there is a chance that you actually can you can not necessarily get rid of the reservoir, but at least fully suppress the virus to the point where your immune system can take care of the rest. The antiretrovirals obviously have toxicities associated with them. We know that with the perinatal prophylaxis that we're using, zidovudine for AZT, you're going to have anemia, which is the likely. And if it does happen, it usually resolves by 12 weeks after having stopped the medication. So it's a transient anemia that you see. If you're using nevirapine, rash is always a possibility, nevirapine being one of the non-nukes. Rashes are very, very common amongst them. And very, very rare, there could be a case of hepatotoxicity. This becomes more important from the adult population because it's based on concentration of CD4. But given that you're only on, given the way that we do it is only 3 doses of nevirapine, the possibility for hepatotoxicity is extraordinarily low. With regards to treatment, the biggest that we have to worry about from a short term is hypersensitivity reaction, notably to abacavir and the presence of HLA-B5701 type of mutation. If that is present, and we do that as a baseline test for anyone before starting antiretroviral therapy, if it is positive, then you are not going to use abacavir because there is an increased risk for developing a hypersensitivity reaction and an even higher risk of a fatal reaction if you were to stop the therapy of abacavir and then restart it, which you know is a potential problem for anyone who has relative non-adherence, or if they don't have a choice because they ran out of the medication, they didn't bring it with them when they went away, or the pharmacy is closed, they can't get it in time, there's a possibility that it could happen that's unintentional non-adherence. So if they do have HLA-B5701, and we also do it in children, if they do have it, you never prescribe abacavir. And it should be put into the allergy list to make sure, since we put other things in there that people don't have real allergies to. Rash, obviously, as I said, most of the non-nukes are going to cause rash, and you have to determine, is the rash real from an actual allergy? Is it possibly the beginning of a hypersensitivity reaction? Or in the case of efavirenz, is it just a drug-associated rash that then resolves? And a lot of these drugs do cause some form of GI intolerance, which, as you know, in kids is very, very difficult. During my training, I worked at a summer camp for families with HIV, including infants and children, and they forced us to taste everything that we were giving to the kids. And for one of the drugs, nelfinavir, one of the protease inhibitors, it was a blue capsule or tablet that had a paper wrapping around it. I don't know why. And then you had to smush it, basically pulverize it, remove the paper, and then we tried mixing it with things in order to make it easier to take, like peanut butter. And when you have a 2-year-old, as you all know, who doesn't like what's being put into his mouth, it ends up going everywhere, including your own mouth. And I didn't eat peanut butter for 2 years after that. It tasted that bad. I was like, I feel so bad for you. Long-term safety issues that we have, notably with protease inhibitors, are going to be changes in the lipid profile. They're quite notorious for doing that. And some of them can also cause kidney stones. Notably, indinavir is the classic one, but we hardly ever use that unless we're dealing with multi-drug resistant. But also atazanavir has been associated with it, or what's known as tenofovir, notably the TDF formulation, is associated with renal tubulopathy, a proximal renal tubular acidosis, up to the point where it could cause Fanconi syndrome. And there is an association with a decrease in bone mineral density. And this is part of the reason why they ended up trying to figure out a better way of doing tenofovir. So the TDF formulation, about 90% of that drug does not get into the cell and gets metabolized within the blood. So there's a high concentration of the active metabolite sitting in the blood. The newer formulation, the TAF, about 90% of that drug gets into the cell, and of the remaining 10% that doesn't, it does not get metabolized by serum enzymes. And so as a result, the TAF formulation has not been associated to date with significant renal issues or bone-related issues. The bone issue With tenofovir, we know that after starting tenofovir, usually within 8 weeks, you can measure bone mineral density, and there is a decrease, a decline. And it will go down to about 1 to 2 standard deviations below, at most 2, within 3 months, and then plateaus there. Once you stop the TDF, in the majority of cases, that bone mineral density comes back up. Obviously, in children and adolescents, this is potentially a big issue since they are growing. And looking at infants who were perinatally infected and put on medication, including tenofovir, going into their adolescence, there has not been an association of true shortened stature or increased risk of fracture. Throwing that up. But still, we like the newer version because it's also smaller. Zidovudine classically causes a macrocytic anemia. It also causes a bone marrow suppression. So when it comes to board exams, for all of you residents and students that are there, when it comes to board exams for HIV, since medication changes relatively rapidly, they tend not to ask you what to prescribe, but they'll ask you the side effects. And for zidovudine, the macrocytic anemia, you're measuring the MCV, which is elevated, is the indication that they're on zidovudine. And back in our training days, we used to use that as the poor man's indicator for adherence. So if someone says, oh yeah, I'm taking my meds all the time, la, 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 and you're like, no, you're not, because your MCV is normal or actually low, and so there's a problem. Depression, so now flipping from drugs to the actual side effects, depression has been associated with every single non-nuke that there is, and with some of the integrase inhibitors, which has become a little bit of an issue, especially with dolutegravir being our biggest gun to date. There has been associated depression. There has been also associated suicide risk with efavirenz, as well as with efavirenz getting these weird dreams and nightmares, which is why efavirenz has been pushed to an alternate regimen, not a preferred regimen. Hepatitis is also common for all those non-nukes. Just remember that from the nevirapine being in that area, so really any of those can cause hepatitis. And lactic acidosis was traditionally associated with all of the older nukes. The newer nukes, like emtricitabine and tenofovir, tend not to and abacavir, tend not to have lactic acidosis associated with it. But it was because all of those thymidine analogs would affect the mitochondria, so they would end up with all these mitochondrial dysfunction causing lactic acidosis. Drug-drug interactions are always important, and there are two big ones, and that are steroids with protease inhibitors. So any of the protease inhibitors that you're on, notably because they are all boosted, it's really the boosting agent in addition to it that greatly increases your steroid concentration. And as a result, can cause Cushing syndrome and adrenal insufficiency. So for example, ritonavir with prednisone can increase the AUC, the area under the curve, by over 300-fold. So it's like, yeah, you only need 0.1 milligram, here you go. And that's the same as like that. However, beclomethasone, as an inhaled steroid, is actually quite safe. And the steroids here include oral as well as inhaled steroids. Oral contraceptives, because as adolescents, they end up being on them because of sexual activity or for other reasons. And we know that protease inhibitors and the non-nukes do reduce the efficacy, which becomes important because of the risk of pregnancy now. And the integrase inhibitors really have no interaction with oral contraceptives at all. So those tend to be more preferred when you're on it. There are other more specific drug-drug interactions, but I kind of wanted just to focus on the big ones that you would really come across. But some of them, for example, you can't take with proton pump inhibitors or any other acid blockers, et cetera, or if you're on certain seizure medications, but it's things that we don't even use in pediatrics. So we did before getting exposed, then being exposed, and now looking or having infection, and now having post, which is after getting exposed, but not necessarily getting infected, so how you prevent this. So we saw that with perinatal, what we use for post-exposure. But in the non-perinatal period, we divide them into occupational versus non-occupational. For you, it would mostly be occupational that we would worry about. I don't want to personally know about your non-occupational uses, but that's what it is. So for occupational, it would be a percutaneous injury or contact with the mucous membrane or non-intact skin with any potentially infectious fluids, and that includes CSF. For non-occupational, would include sexual assault, condom malfunction, high-risk sexual activity, which includes injection drug use, or the pairing of drug use with unsafe activity. It's all going to depend on the viral load of the source. Sometimes you know, sometimes you don't know. So if you can determine if the source actually is infected or has detectable viral load, that's going to influence your likelihood for use of prophylaxis as well as the potential for infection. The volume of the exposed fluid, so using a very small butterfly needle is very different than using a large hollow bore needle and the potential for volume of exposure. As well as the duration, how long it's happening, and that is more likely to occur with non-occupational, since once you get a needle stick, you tend not to leave the needle in, right? I hope. So what you have to do is, obviously, for the exposed individual, you need to exclude HIV in that person to start with. You're going to screen for other transmissible diseases. We do have post-exposure prophylaxis for Hep B, but not for Hep C. You want to start early as possible, within 72 hours. That doesn't mean that outside of 72 hours you can't use it. It's just that the efficacy is much, much, much less. And so the recommendations are only within 72 hours. And again, we use a 3-drug regimen, which is why there is that push in intense research looking into using a 3-drug regimen for perinatal prophylaxis. And the current recommendations are 2 nukes with an integrase inhibitor. So what we have downstairs in our ER, if this were to happen to you, we have blister packs for this. And the 2 nukes that you get are the emtricitabine with tenofovir, TDF in this case, and the integrase inhibitor is raltegravir currently. The newer integrase inhibitor, dolutegravir, can also be used. Personally, I think that might be a little bit easier on the individual, since the 2 nukes are dosed once a day and raltegravir is dosed twice a day. There is, as of 2 months ago, a once-daily form of raltegravir, but it hasn't been studied for post-exposure prophylaxis, whereas dolutegravir is also once a day. So having a concordant regimen where you take all of the pills at the same time, or at least in the same fashion, once daily or twice daily, is easier to do and to remember than to do a discordant regimen. Because I can imagine if any of you take even such things like a multivitamin, your adherence probably isn't 100%. Maybe because you're sleeping until 1 o'clock on Saturdays, but I mean, it's just... You're going to retest the exposed at 6 weeks, at 12 weeks, and then somewhere between 4 and 6 months after. And the 4 and 6 months after depends on which test that you're using for it. So usually once you get those 3 and you test negative, you're deemed not to have been infected after the exposure. So now knowing all of that, here's your post-test. So in which of the following situations is the use of antiretrovirals or post-exposure prophylaxis for the prevention of HIV appropriate? So again, you've got this pediatrics intern who sustains a needle stick during placement of a central line, which is not a butterfly needle that you use for that. In a 17-year-old who was perinatally infected, and the issues surrounding perinatal infection, especially in adolescents, is adherence and the potential for multi-drug resistance. 17 years ago, our drug options were different than what they are currently. A 16-year-old homeless adolescent male who exchanges sex for money in order to live, and a newborn infant whose mother had not received any prenatal care but does have a positive rapid test. So in which of these situations would you use prevention, post-exposure prophylaxis? So all of the above, and yes, like I said, just because it's there, it's usually the right answer, unless I'm doing the test, which some of you know about. So the take-home points for each of these. For PrEP is that it is an effective option for prevention in high-risk patients, including adolescents. However, it is not 100% effective, and we know that it does not prevent sexually transmitted infections. We also know that the greater your adherence, the greater the efficacy. Based on certain studies, we know that you need to have a minimum of 4 times weekly of the drug. That's the minimum that you need to have demonstrable concentration of the drug for protection. We prefer daily. And PrEP should not be used alone. It needs to be part of a complete package of prevention services that you're providing the patient, including education, counseling, support, and routine monitoring. And in the adolescent population, that routine monitoring should be more frequent. For perinatal post-exposure prophylaxis, the earlier you start it, the better. You're seeing a general trend here. The length is going to depend on the maternal history. So if the mom is completely undetectable, you're only going to do 4 weeks. If there is any potential detectability of viral load or non-adherence, you're going to extend it to 6 weeks. Generally, there is a very, very low risk for toxicity for the infant, which is what we always worry about with drugs. And you need to continue testing, or potentially even more so, for those infants who are at higher risk. And if they are found at any point in time to have converted to be known infected with HIV, you're going to, if they're still on post-exposure, you're going to switch it, or if they're off of it during that post-time and you find it, you're going to want to start antiretroviral therapy. We know that urgent treatment is recommended for anyone under the age of 1 year. And for the treatment, again, the earlier you start, the better. We do resistance testing before prescribing, including in the neonatal period or the young infant period, mainly because of the potential for resistance for the drugs, as we saw. A triple drug regimen is the norm in general, so the preferred drugs are going to depend on the age and weight potentially, but all are going to use those 2 nukes as your backbone. Adherence, just like with PrEP, is of paramount importance, and keeping that in mind. And if you do have to stop one drug because either of a side effect, tolerability issue, you need to stop them all, not just pick and choose which one I don't want to take. And of course, monitoring for your adverse effects and drug-drug interactions. So at the end of this, since you should have access to this, I provided all the antiretrovirals by class, and in bold are the ones that are most commonly used in the pediatrics world. But in reality, all of them can be used. It's just depending on the age. And then just all the resources. I have time for questions.
Sorry, I saw a hand up. Go up front. I'll be right back.
Thanks very much for your talk. I wanted to know, can you describe what resources are available at Carilion for pediatricians who are taking care of patients who might be exposed to HIV? Are you running a clinic? Do you prefer to work on a consultative service?
I guess it depends where, but we do inpatient consultation. There are 2 of us who do specialize, per se, in pediatrics. I mean, I'm trained in pediatrics. Dr. Kirkering also, for how old he is, for his experience with pediatrics. We're the 2 who mainly see all patients, either inpatient or outpatient. Any of our pregnant moms within our HIV clinic, I follow all of the children. And not from a primary care perspective, but only from the post-exposure perspective. And so I work with pediatricians there. For an outpatient, then consultative is the best way to go, including for pre-exposure prophylaxis. And I put a priority on children. So make sure that I get them in, even if my secretary says, oh, he doesn't have available for 3 months or anything.
Okay.
But,
so,
that out?
Yes. So a woman who's pregnant who has an HIV exposure, the expectation is that you will be seeing the child after she delivers. Okay.
We still need to be notified.
Mm-hmm. Okay, sure. Yeah. I had just one more question regarding, could you clarify, you talked about pharmacogenetic testing, and is that just if you're planning to do abacavir, you need to genotype for the HLA, and otherwise we're not genotyping at this time?
Correct. Of any HLA, yes.
Yeah. Mm-hmm.
We do genotypes for the virus for resistance, but that's separate.
Okay. Thank you.
I just had a question. Can you clarify the bottom line on breastfeeding in maternal child transmission, especially from a developing world status?
So there are 2 studies that are currently in process in Africa looking at the use of continuing breastfeeding as well as antiretroviral therapy. And the preliminary data that has been presented in poster form shows that there is no significant increased risk for infection for those who are breastfeeding but on antiretroviral therapy. In the United States, it is still recommended against breastfeeding because of the studies that have been performed in the United States have not been large enough to be able to demonstrate that there is protection or that it is safe. That being said, some providers do allow it. As I tell them, I'm like, I can't prevent you. I mean, I'm not there to slap the baby away from the breast. But, so if you do it, but know that there are risks associated with it. And I have had one mother who did breastfeed for 7 months, and the baby is still uninfected.
For the pre-exposure prophylaxis, I did a little quick Dr. Google search, and it came to the tune of like $1,200 a month for the cost of that medication. Has that been your experience, and can you get it covered by Virginia Medicaid or the other insurers in the area?
So insurance carriers are becoming a little bit more accessible for it and for coverage. However, the company that makes the only drug that is available for it does have a very good patient assistance program. So it does make it more available. In many of the bigger insurance companies that we may have to perform a prior authorization for it because it may come across their desk as, well, you're only giving one drug, or really two, for antiretroviral therapy, and that's not appropriate, so there's got to be a reason for it. But about $1,200 a month is correct, unfortunately.
So the number you put for the actual transmission rate was like 25 to 40% perinatally. Is that just birth, or does that include like the postnatal period, like breastfeeding as well?
That's including all of that, but that's without any intervention. The mother not being on antiretroviral therapy and the infant not getting any post-exposure prophylaxis.
So what's the actual efficacy of like perfect adherence, PEP?
For the infant?
Yeah.
The transmission rate is less than 1%. Apparently I should have stopped earlier.
All right. You might have to walk up here.
I have two kind of related questions. One, if you have a patient who's been prescribed pre-exposure prophylaxis, but they're not super consistent in taking it, and they're, I guess, willing to admit that, is there concern for development of more resistant strains of HIV in that patient and or from a public health perspective? And also, what do you do with that patient?
So based on the studies that have been performed looking at the potential for resistance after being infected in the PrEP trials, the only ones who developed true resistance to either of those two medications were associated with individuals who were already infected with HIV before even starting the PrEP or very early on. What we have found is that there are cases who long-term out, months to year out of PrEP and taking it, that the drug, that the virus that is acquired tends not to have the resistance. Or if it does, it tends to disappear relatively quickly. Sorry, what was your second one?
I think, what do you do with those patients who
are non-adherent, besides smack them? Well, it depends on what their ongoing risk is, and discussing the importance of adherence and probably more increased follow-up with it. I will admit that I haven't had that experience to date, and I do have a 17-year-old who's on. And, of course, I am believing him, but because we don't do therapeutic drug monitoring. But it's really going to be reinforced. That's where all the support comes in, so a lot of reinforcement.
A question about babies that would potentially be adopted from high-risk areas. Would you recommend routinely screening when these babies potentially came to this area, or kind of the watchful waiting, and in what areas would you feel more concerned?
I'd be a little concerned with the watchful waiting, depending on how old they are. But I would say that from any infant who's adopted outside of the United States where there is no significant information from the maternal history, that all those infants should at least be screened for HIV. And then based on that, go. And then I guess based on that, you'll have your watchful waiting depending on their exposures afterwards. But.
Any other questions in the room? We've got maybe 2 minutes, and we've got quite a bit of people on the phone. So.
Okay.
Second. All right. I'm going to unmute the phones here really fast. If you are on the line and you do not have a question, please just put your phone on mute so that we don't hear your background noise.
The conference is now in talk mode.
If anyone on the line has a question or wants to make a comment, now's your chance. Anyone at all?
You want?
Yeah, exactly. All right. Any more questions in the room? All right. Thank you very much.
Thank you.
If you are on the line and you like to email us a question, you can at outreach@carillionclinic.org. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.